And then the nice thing, even though we are going to scan the abdomen afterwards, there is no need for doing applying any bellows on the patient. So bellows for respiratory gating or so, we will use our navigator technique to do so. And what I'm doing here is I position the air coil just with a slight overlap on top of the head coil. Air coil technology allows us to do any type of overlap because the air technology in these coils avoids to have decoupling of signal when coil element would overlap. So as a technologist, I really don't have to think too much about how I position the coil on the patient. I can do anyhow a setup which is sufficient for that patient. So in case I would have a big patient where I have a big abdomen to scan or a pregnant woman, I can also put the coil in the other direction to scan. So, but here in that case, I want to have a large coverage, maybe do a quick Plexus scan on top of it. That is why I will position the air coil just like that. I don't have to put bellows, as I said, and then for our landmarking, we don't have to let the system know where the coils are on the patient. I just have to landmark where I want to start scanning, and in that case, I'm going to landmark the brain with one mouse pick, and then the scanner table will go into the bore without any additional touch from my side. Do you have this result?
Okay.
But I can hear me. I don't want.
So now we are back here at the user interface in our scan operator room. I already typed in all the information for the patient. I launched the protocol, and then I'm going to start the scanning session. And as you can see here on the lower right corner, our user interface for the coil setup has changed. So what we do have seen differently here is that we select an entire coil and not modes anymore. And I've plugged in the head coil. The PA coil embedded in the table is always plugged in, and then the air coil on top of it. And I will go ahead and start a normal 3-plane localizer here. The air touch is working as following. So what we do before we start a scan, we will do a coil calibration. And you can see here in the outer view in the upper right corner, something showing up for 3 seconds saying coil calibration. So what we do during that time is we do turn off every single channel which the scanner has and all the coil elements in that field of view. So after the 17 seconds, the scanner knows exactly where the coils are and will pick accordingly, which really makes it easier on the technologist. So I can move now freely through the body, and when I want to know where the coils are in the certain body part, the system will always generate this sensitivity map and will do plan accordingly. So we will start in the brain. And the other thing we want to show quickly is that we have our first deep learning on the scanner also on our 1.5 portfolio. So here the slice prescription has been done with RX. So slice prescription is selected here on the user interface. So we have certain landmarks where we can select, and we've selected in that case the ACPC line and the actual plane. And that was really our very first deep learning on the scanner, where we've trained where the landmarks are on the brain, and will define those landmarks after a normal 3-plane localizer, which is really huge. So you don't have to acquire a 3-dimensional localizer or do anything. You just have to run a normal 17 seconds localizer, and after that scan, all of the landmarks have been already defined. So when you decide to do something else, the localizer is done, you can just go ahead, pick the landmark needed, and we do offer landmarks such as temporal lobe, the inner ear, the OM line, the orbis, the optic nerve, the pituitary, and even the circle of Willis. You can save those things in the protocol, so you don't have to worry about that. That again helps a great deal in being consistent. So when your patient is coming for a follow-up because he's a tumor patient or an MS patient, there's no need to get all images on the scanner. You don't have to look how you prescribed the last time. Every time you use RX, the system will do the same job, and that really helps a lot.
Yeah.
So we tried in-house to beat the deep learning machine and try to be better, because we think with our 15-year plus experience, we are better in slice prescription than a machine. Unfortunately, we have to admit we always lost that game.
And on our virtual booth platform, you'll see some nice videos where we had done some tests earlier, where we had the patient or the volunteer had their heads in different positions, and all three of us scanning, trying to see what the images would look like. And all the images look identical pretty much. So it's a really nice feature for consistency. And
also we did the test like without using RX, and then we saw always a slight difference. So even though we think we did a great job, actually, yeah, as we said, the machine was better. So I want to do quickly before we go to our abdomen show you something else, and that is a Plexus Scan. Because that is also a sequence where at the beginning, as a technologist, there was a lot of struggle, since the sequence is, there was always hard to make like good images for the doctor. But now what we do is we offer a 3D sequence, a cube, with a flex technique, 2 contrast, which is a 3D sequence. And we can just like prescribe a normal coronal plane over the nerves and the nerve's roots, and then the scan is only 3 minutes 25 seconds, since we can combine different types of acceleration, hyper work methods, and we can like reformat, so we have really nice images of the nerve roots in the cervical spine. And we do that all like with one coil setup. So in the next scan, you will see that the system will understand that the air coil is already closed on his neck, and will pick accordingly, so that we can see the nerve roots going down to the humerus as well. So that is why I go ahead and start to launch the next localizer. I will just prescribe the slices here. And as I said, I use HyperWorks acceleration technique. So HyperSense is picked with a factor of 1.2. And then on top of HyperWorks, I selected HyperCube. And that is done here with the excitation mode to focus. And that means now that in phase direction, I selected here right-left phase encoding. I not have to worry about the shoulder and rep, because I will read out only in the field of view here, and have only the excitation in that field of view. So that ends me up with a scan time of 3 minutes and 25 seconds. So I will go ahead and just show quickly before we continue scanning what will happen to the sequence in case we don't use our HyperWork feature. So I will deselect HyperSense, and then I will also go ahead and deselect HyperCube, and you see that the scan time is 1.5 minutes longer. So with HyperWorks, we can like end up in a really decent scan time, and we do have an isotropic pixel size of 1.2 millimeters. And the other thing which we can here already show is that how great AirTouch does understand where the coils are and which coils to pick. So here in that sagittal view, you can see that the HNU is selected, and that is the bar in the back of the patient. And then here starts the coil select elements from the posterior elements in the table. In the front, we have the anterior coil of the head, and then again, we do have partly the air coil. And the system selects the coil which are needed to really maintain good image quality. And the only thing you have to do as a technologist and make sure is to plug in the coil. That's all you have to do. Okay. So then we just go down, and we will continue with our free breathing liver. And therefore, I just want to find the liver. So I just go ahead and prescribe my localizer in where I hope the liver will be. Okay. That's where we go. And then we can look already at the first images acquired in the brain. I will launch the 3D volume viewer. And here are the first T2 images acquired. I forgot to mention that we acquired a propeller technique, so our motion corrected sequences. So in case the patient would have some motion, we wouldn't have to worry about that. The scan was only 1 minute and 49 seconds, and we have the entire brain covered with 4mm slices and a good implant resolution here as well.
And just to remind everyone, if you have any questions, we encourage to ask. If you wanted to ask something, just please put it in the chat for the Teams meeting, and we'll be able to see that.
So for the abdomen, we are going to scan free breathing, which we will do with our navigator technique. The nice thing, which I want to already mention now, is that we can combine these methods with all contrasts. So we were used to have a navigator available for long TRs and TEs. So all the T2 imaging is easy to do with a navigator, but that we can do also T1 sequences with a navigator is really huge. So if you have a patient who is not able to hold their breath or is old, maybe cannot hear you at all anymore, then now you have a tool to offer all contrast with free breathing.
And even some of these new sequences or sequences like LAVA that are T1 weighted, the new offering that's coming will also be able to use hypersense on those. So you're able to get higher spatial resolution with a very minimal impact to scan time for those.
That's nice too. So the scan time will even be faster. So now the table is moving down to his liver, and we will just generate the localizer on the liver and the diaphragm. And then we will continue again with our propeller technique. So we will now combine two methods to really have nice, less motion sensitive images, because we will combine the propeller technique, which is kind of generated and read out in the blade technique, on top of with navigator. Okay, localizer is running. And again, it happened that the scanner will do the sensitivity map to really understand where now the air coil is on the patient, so that we don't have to worry about thinking now, for example, deselecting the head coil or things. We don't have to think about it. The system will do that for us. So now I can go ahead and set up the sequence. I will just pull it over one more time. And I want to scroll through the image here first, because I want to highlight that the navigator, which you can see here covering the diaphragm in the perfect spot, has been placed automatically. So it is placed automatically because what we did after the localizer, we told the system, please do a post-processing task. And this post-processing task you can see here is labeled as auto tracker placement. So the system will, as soon as the localizer is done, find your diaphragm and place accordingly. And that, again, helps a lot with consistency. And no matter how often you do an abdomen scan, you don't have to worry about that. You will always easily can use that tool, because you don't have to place the navigator. So, and as I said, we will do the propeller technique combined with the navigator. So he free breathe all the time, and we will scan for 3 minutes and 12 seconds. And while this is running, we can look at our images which we acquired for the neck, for the plexus. So I will load the middle slice here, and then you can see when I bump up how nicely now you can see the nerve roots here. And since we scanned with the air coil on top of the head coil, you see that you can go through the entire nerve roots until they hit the humerus. So that is something when I had to start scanning plexus, I can admit that I hated that examination because I never was able to find any nerve. But now with having the 3D sequence and cube available and all these coil management available, it's so easy to do. So now I wouldn't bother anymore when somebody came and just say scan a plexus.
The nice thing with this too is you've applied flex with this, so it's a Dixon technique. So you're going to get a lot of data with this particular 3D volume. So you're going to get the in phase, out of phase, fat image.
So that is what Steve mentioned. Since we did the Dixon technique, I will show you in the other image here the in-phase image as well. So everything has been acquired in one image, and you have all the data available and ready for use.
The Cube has a lot of compatibility, really, with multiple different types of tissue contrasts. You can do, a T1 cube, T1 flare cube. You can apply Dixon to those. You can do T2, T2 flare, VIR. So it has a lot of versatility in how it can be used.
Yeah, that's really the nice thing that Cube, any contrast you can think of can be done with Cube. So here's maybe something good happening, what is happening in real life too with our navigator. So the patient obviously changed his breathing pattern. So at the beginning, the tracker was able to find the diaphragm and was always triggering perfectly. But then obviously my volunteer, our coworker, seems to fall asleep in the bore, which is totally fine. That happens in your daily routine as well. So what you saw here is that the breathing pattern changed and the curve will flatten. So my first set threshold doesn't fit anymore. So usually the scanner would pause or stop and you would have to readjust and think about your breathing pattern. With our navigator, you are able to change the threshold while. That is what I did. So the threshold was all the way up, and now I brought the red line down to again match his breathing pattern. So luckily now the scan doesn't stop or interrupt. I can just continue scanning, and I don't have to talk to my patient and try to motivate him to breathe in a different way. So start breathing faster again. Again, I can change my threshold. So it's really a nice tool to always make sure that I can continue the breath hold in one scan. Okay. So now the next sequence, what we're going to show is a diffusion sequence. You see that we have set up two different B values with 50 and 700. And we will use our navigator. And on top of the selected B values, I also have selected to synthesize the B value. That is a feature you can do anytime you've scanned two B values. You can go up and synthesize any B value higher, which really gives you, again, the efficiency that you don't have to scan high B values with a lot of averages.
Yeah, saves you a lot of time, right?
Saves you a lot of time, right?
Yeah.
Okay, and then we just show you an image and how nice the coverage is with the air coils. So I'm just going ahead and we'll do a single shot sequence in breath hold, and we will cover all the way here from the liver down to his pelvis just in one scan. And then I want to show you that with the air coils, you have a different advantage. Not only that you are able to really have a nice lightweighted coil for your patient, which is really fitting the patient as a blanket. You don't have to do additional straps or things on the patient. It will just fall around the patient as a blanket. So you will get a lot of signal from the sides, which I was never able to do before. And now the other advantage, which we want to talk about and show a little bit, is that since you have so many channels in the field of view, that you are now able to accelerate higher. So when we had old coil designs with less channels, then we would allow you to accelerate with a factor by 2. And now with the air coils, we have 30 elements in the front of the patient. The table is 40 elements in total. So we have way higher channel count in the field of view. So what we're going to do is now we want to compare the images. It's a 2T single shot with a large field of view when we do use acceleration by 2 and by acceleration by 3. Because what we will see is that the image quality will stay the same. So this high channel count allows you to really go higher with the acceleration technique and allows you, again, to be way more efficient.
In regards to these coils, this afternoon session, we've got something interesting planned where we would like to review a lot of the coils and positioning with the air coil. And then we also have 2 smaller coils than this anterior array. We have a multi-purpose coils that we'll be showing and how that, you could use those to position exams and really take advantage of having those coils positioned is really great for the patients, very comfortable for them. So we'll show you some examples of that in this afternoon session.
And here you see the free breathing T2 image, which we just generated. The scan time in total was 3 minutes. You can see that there is really less motion because we were combining 2 methods. As we said, we were combining the propeller technique and the navigator. So that really always gives you a good result, even though the patient, as you saw, was falling asleep in the bore. And again, I have my tool here to watch the breathing pattern of the patient, and if he would change the breathing, I can immediately just change the threshold here as well. One other thing which we can talk about while this is running, we don't have to scan it, but I want to show how easy really an air touch is making your workflow here. So we have now a small S2I coverage. So maybe I go even smaller with maybe only 8 slices. 8. So, and as you see, the coil setup is shown here again on the localizer with parts of the head coil, then the area A coil in the front. And when I move the stack around, you see that as soon as I keep when I leave the mouse click, that the coil has been picked accordingly. So that is really something which saved my life a big deal because it happened a lot. I admit that when you have like these exams where you want to switch coils, that you are busy with maybe answering the phone, you have to like talk to your coworker or so, then you forget to select coils, and then you scan for 2 or 3 minutes without having the coil selected accordingly, and then you see it's all black. But now I can just make sure that the software is picking the right coil element, and I don't have to worry. So luckily, after using AirTouch, it never happened to me again anymore that I'm scanning sequences without the coil selected.
So Sam Shepard asks, can you combine the air coil with another multi-purpose coil to cover more of the patient in one go, i.e. head to toe?
Yeah.
Yes, sure. Yeah, we'll be able to combine these. AirTouch is going to be very seamless across the coils, just like this, combining multiple coils for anterior placement, no problem. Are you using Air Recon DL on any of these sequences? On this scanner, we are not using Air Recon DL. Today, we have to receive CE marking on the Artist system before we can show that. If interested, towards the end of the session, I could probably pull up a few cases to show you. But right now, this system, the software we're running today is not using that, but it will be coming to SIGNA Artist. So.
Yeah. And back to the MP coil stuff, you can really set up, and we did that here in-house, like starting scanning in the liver, and for some reason you want to scan the knee, you can just wrap around the MP coil around the knee and just start in the liver and go to his knee and do that also in one setup.
Yeah.
So that's really makes you as a technologist lazy. You don't have to leave the chair at all anymore. Okay, and then I think we want to go ahead and end up our session with just doing one scan in the pelvis, and therefore, again, I will run my localizer down in the pelvis area here. I will delete the other ones. And I will upload the diffusion sequences here as well. So here you see the B50 value. You can see it in the upper right corner, and I will go only to one slice. So we do see that there is really less distortion in these images, and that it's really nice because it was using the navigator technique, so we don't have to worry about breathing artifacts and such. And then I'm going up to the higher B value because that is the one you want to challenge me on, because the higher B values are the ones who usually tend to have less signal. But as you can see, also that sequence has a lot of signal here. And then I can just launch and go ahead and show you the synthesized data as well. So here, remember, we picked in the protocol a high B value of 1000. You can see that here, that we now do a 1000 B value as well. And this one is the one which has been calculated, so it has not been scanned. So that technique we call magic diffusion has really a lot of value everywhere in the body where you want to have high B values, but you don't want to scan them, and you want to save some time. So then I can go ahead and we can compare the two single shot sequences we just did. So remember, we really picked a large field of view. And what we did here is we can cover with one coil the liver and the pelvis. You see, we are almost halfway in his femur here in one scan. And the difference between those coils is the acceleration factor. So on the left hand, let me just quickly prescribe the slice in the prostate, and then we can talk a little bit more about that. So I will do one more sequence in the prostate. Therefore, I will use the localizer from the pelvis, and then just prescribe slices here over his prostate, and I will use again propeller technique. We will do 3 mm slice thicknesses, and we have implant resolution of 0.8 by 0.8. And as you can see, plenty of coverage with the air coils. No need for me to go inside in the scan room and change the coil setup. And then again, here is the single shot sequence. Left-hand side was done with an acceleration technique of 2. That is why we had one breath hold of 12 seconds. Right-hand side is acceleration by 3, and we have only 9 seconds of breath hold. You see, when I scroll through the image, that you don't really lose any detail. You have the same image quality. You can just be faster. And I think that is really one of the biggest advantages on top of the patient comfort and the versatility what the air coils will have. So these high channel counts allows you really to play with the acceleration technique, which we were not able to do prior.
I know we're nearing the end of the call. Just quickly, I know that there was some discussion around Air Recon DL and it being on SIGNA Artist. I do have a few cases here, just as a quick example. I know this is a brain exam, but I can quickly show you this. So this is an example of a 5-minute brain exam. Really great image quality. 49 seconds here for the T1, T2 flare, 1:17 for this example. All these prescribed with the AirX too, so the automation is very easy to do. Here's the same one, just an example with and without Air Recon DL. So this is a 3 mm temporal lobe, which is 0.6 resolution in plane. You can tell the images on the left without Air Recon DL, the images on the right with Air Recon DL. So yeah, it's a great solution. I think you'll be able to do a lot of very fast imaging with this technology. So exams can be done, a lot of them in less than 10 minutes quite easily, so no problem with that. I think there was one question in the chat about doing a live demonstration of the use of coils. That will be done in this next session this afternoon, not necessarily in this session, but we would be glad to show you that. A lot of examples of how coils could be used in the 1 o'clock session today. And what is the z-axis field of view coverage on the coronal? So it's 50 centimeters that we acquired there. So.
Yeah. The air coil itself would have a coverage of 65 centimeters. So in case you want to cover that, then you can just do 2 stacks and paste the images afterwards without changing any coil positioning. So that is also what we've seen a lot of people done when you think about like maybe a long bone or something and you want to like cover more than 50 centimeters, because the coil coverage is, you can utilize the entire coverage by just using 2 stacks and just paste them up afterwards each other. But other than that, we have a 50 centimeter when you want to cover it in one field of view.
So we have about 30 seconds left for this scan. If any more questions, feel free to ask. Be glad to answer any of those.
And other than that, we just want to remind that, that we started in the brain with really like nice images there, and then now we are ending up in the prostate, and we both lazy people never left the chair. So we really love our new technology because that really helps a lot to be efficient and to be fast. And I really changed a little bit my behavior because I now do just pick coils and put them on top of the patient, even though I might don't use them, but I still have them available, which is really, really nice. So now here is the last scan of the prostate, which we did. There was the 3-minute scan time, and I will zoom in a little bit more. So all done, as we said, like when starting in the brain, ending in the prostate, only 3-minute scan time, and we are on 1.5 Tesla. We shouldn't forget that as well.
All right, guys, so that will conclude this morning's session. So a little bit this afternoon, as we mentioned, we have another one. So we hope you guys can make that too, to see some of our intelligently efficient solutions.
Thank you so much for your time.
Thank you.
Bye.